Alors, je vous présente le prochain conférencier, qui est Dr. David Zielinski. Dr. David Zielinski est inhalothérapeute pédiatrique à l'hôpital... OK, ben je les excusez. Et pneumologue à l'hôpital de Montréal pour enfants. Il a un intérêt spécial pour les maladies neuromusculaires et la ventilation mécanique à domicile, invasive et non invasive. Il est le co-auteur des plus récentes lignes directrices de la Société canadienne de thoracologie sur la ventilation pédiatrique à domicile et est directeur médical pédiatrique du Programme national de ventilation à domicile. Il est aussi président du réseau de neuromusculaire et de ventilation à domicile de l'American College of Quest Physicians et dirige le programme d'inhalothérapie pédiatrique de l'Université McGill.
Well, thank you very much, and thank you very much for the invitation here today. So I'm actually missing my disclosure slide, but I don't have any disclosures relevant to this presentation. So what we're going to do, the goal kind of here today was going to be to review our recent Canadian Thoracic Society clinical practice guidelines on home ventilation for kids. And as we kind of go through this, I'll show we have about 75 to 80 recommendations, so I'm not going to sit here and list them because that'd probably be a very, very dry and boring presentation. So we're going to talk a little bit more about the background in terms of how we came about doing this guideline, some of the processes involved, and just touch base on a few specific recommendations relevant to neuromuscular disease especially, around screening for sleep disordered breathing, initiation, and then depending on time, looking a little bit about what we're recommending for monitoring kids who are on home ventilation at home. So just as background, I think everyone here knows this well, mechanical ventilation started with the negative pressure ventilators back in the 1950s and the polio epidemic. And this is actually the same girl who was about 25 years later still alive with the same iron lung. Many of these individuals transferred over to positive pressure ventilation eventually. As we move forward towards the 1970s, in the late 1970s, the very first home portable ventilator became available. And it actually, when you look at the cost right now, it would be about $11,000 US in today's dollar. So that actually, the costs have stayed pretty stable to what we see today with the trilogies, which are in about the $10,000 to $20,000 range for us. By the 1980s, the progression was to try to get these kids home. And this is actually a girl in Ohio who was living in the hospital after a neurodegenerative accident, and they wanted to bring her home, but the family couldn't afford to bring her home, and she didn't qualify for Medicaid because the family had too much money. So it went through a large, it actually went all the way up to the U.S. Senate, and it kind of helped her get her home. But that was in the 1980s. We're still facing the exact same difficulty here in Quebec today in getting people home and getting the supports home for them. So if we look to see what's been happening in Canada, the first description came from Winnipeg from the 1993, and they looked at 22 kids that they've had a long-term ventilation from 1979 to 1992. So really starting off with when home ventilators became available. In the early 1990s, Ian McCluskey, who's in Ottawa, started the first home ventilation program in Toronto. And you can see the explosion that they've had over the course of 20 years. They went from 2 patients in 1991 to 156 patients at home in 2011. And these are predominantly non-invasive ventilation. And the number of new starts continues to rise each year for them. And relevant to us here, the majority of these are, not the majority, but the most common diagnosis are neuromuscular disorders, making up 35% of them. The group from BC has published similar data that their clinic has gone up quite a bit, and we're currently about to publish ours looking at our changes that have been happening in Quebec. This is looking at diagnostic trends at the core PNAVD, which includes 14 out of the 18 regions of Quebec. It does not include specifically Laval, Quebec City, Sherbrooke, and the Montérégie, but we do have patients from all of the sites. And one of the things you can see, while the numbers have increased significantly over the course of 8 years, neuromuscular disease has remained really the most common diagnosis throughout all of that, and that's been remaining stable. And in fact, for 2015, we had the data from the entire province. We had 115 kids on non-invasive ventilation in Quebec, and 40% of them were neuromuscular disease. And like everyone else, almost all of our kids are going home on non-invasive ventilation right now. Even our younger infants who are on over 12 to 16 hours a day, we're able to maintain them non-invasively, and that makes up the vast majority of our program. 199 out of the 227 kids that were treated over the last 7 years have been done so non-invasively. So in 2011, the adults at the Canadian Thoracic Society published their home mechanical ventilation guidelines, which is a fairly well done guideline given the evidence that they had. So around the same time in 2012, the Pediatric Assembly was tasked with starting a pediatric version of this. And by 2013, I think things started moving much more quickly. And what had been decided was, let's model this based on what was done in the adult guideline. So they had 12 different sections, and we decided to look at saying, okay, which ones kind of fit with us? We'll do the same ones. So airway clearance, very important, both kids and peds, transition to home, central hypoventilation, etc. We also looked to say, okay, well, we don't have ALS in kids, but spinal muscular atrophy is our equivalent, so we did a section on spinal muscular atrophy. We don't have COPD in kids, but we do have other chronic lung diseases that we do ventilation, so we had a section on that. And there's a few sections we didn't include, like post-polio, because we didn't think it had some relevance. We didn't include congenital myopathies initially because of some of the data at the time and our experiences, although I do regret we didn't do that now. And then we also looked at a few other subsections, including initiation of long-term home mechanical ventilation, monitoring, transition to adult care, and patient and family experiences for that. And as with it, we used grading recommendations. And just to point out, when I show some of the recommendations, 1 means it's a strong recommendation. 1A, which we don't have a single one of, maybe 1 in the whole guideline, is based on high quality evidence, 1B is based on moderate, and 1C is based on low quality evidence, which is basically observational studies or case series. And we rarely have any recommendations that actually rise above the level of C, based on the data that we have. And then 2 are weaker recommendations with the same. And then we also have consensus recommendations for a lot of things where we did not feel that there's enough data to support this. So we were very happy in filing 2017, after 5 or 6 years, this got finally published. There was 2 delays, one of which was, we'll come back in a second, but the Canadian Thoracic Society lost their journal, and this got put on hold for about 16 months while it was already finished because there was nowhere to publish it until the new journal came out. So as I mentioned before, I'm not going to go through all of these, but if anyone goes to look at them, we have certain sections that are very, very useful in terms of general recommendations. So the initiation of long-term mechanical ventilation transition to home really looks at recommendations around what should be in place in your hospitals, what should be in place around your programs, what needs to be done to make sure that we can do a safe discharge home. The ethics really looks on joint decision-making when there's difficulties between families and parents in terms of whether or not we should or should not be doing home ventilation. The home monitoring we'll talk a little bit about during this presentation. The section airway clearance, I think most of us know that airway clearance is a very important part of neuromuscular disease, especially with weakness, when you do have difficulties with our, by the time you have sleep disordered breathing, you usually have poor airway clearance as well on that. And then a few others as well. And then we have and probably not surprising, 70% of these are consensus recommendation. These are really motherhood statements of, we should all be doing this, this is how we should be doing this well, which really, we have very little data behind doing so, with the exception of the airway clearance where there is some. Then we have our specific disease recommendations, where we look at more specifically here. And here, most of our recommendations are at the 1C. So based on observational studies, again, we don't have a lot of data to support them, but we'll go over a few of these shortly now. So the one thing I mentioned is this was actually the very, very first journal of the new Canadian the Canadian Journal of Respiratory Critical Care and Sleep Medicine. So in 2015, so the Canadian Thoracic Society never owned their old journal, which is the Canadian Respiratory Journal. In 2015, the publisher of that journal sold it to another publisher, and that other publisher maybe wasn't a full predatory publisher, but did not have the most stellar reputation. So the Canadian Thoracic Society cut bait with that and started off a new journal. One of the problems when you have a new journal is that it's not indexed in PubMed. So you can't, as of right now, you still cannot find these. If you go into PubMed, you will not be able to find this specific guideline. But it should be available by the end of this year. So if you do want to find it, you need to Google the Canadian Respiratory Guidelines or the Canadian Thoracic Society. You're going to come to the website here. You can go down on the guideline resource menu, click on the guideline library, and then within that guideline library is all of the CTS guidelines are available there for free. You don't have to be a member, they're readily accessible there. And both the adult and the pediatric ones are available there. And within the next few months, we should have the executive summary that we publish is about 38 pages, is a very, very quick overview, but this is really 13 sets of different sections and full guidelines, and that should be published in a supplement coming out hopefully within the next 6 months. So we're just going to talk a little bit about some of the specifics of some of the recommendations and how we came about them and some of the lack of data that we actually had for this. We all know neuromuscular disease and sleep is one of the presentations that we all have to deal with. It's normal for all of us to have loss of muscle tone during sleep. It's normal for us to drop our tidal volumes, have a slightly lower respiratory rate. We all have increased airway resistance. We have less response to CO2 changes, and we all might have a little mild rise in CO2 when we're sleeping. Every one of these normal physiological changes of sleep is something that is making a problem of neuromuscular disease worse. So whereas your patients can often sit and maintain their tidal volumes while they're awake, at some point that starts to change with sleep. So when do we need to look for this, or what are the symptoms? Well, symptoms of sleep-disordered breathing, as you all know, you can have daytime sleepiness, morning headache, failure to thrive, especially in kids, attention, learning, behavioral issues, cardiovascular changes, sweating, fatigue, anxiety. However, frequently these individuals are asymptomatic, especially in slowly progressing diseases where this slowly develops over a period of time. So there's been a lot of work done historically in terms of trying to see when we should screen for this. And I know this is a very small slide that'll be very hard to read, but some of the problems, so we look at here some studies of our population outcomes and predictive measures. They're very heterogeneous and very small numbers of different ages of just DMDs or all neuromuscular diseases. What they're trying to measure is also different from test to test. Whereas today we would define sleep disordered breathing based on PSG, based on having a AHI starting to be higher, or elevated CO2. Some of these looked at just their outcome was daytime elevated CO2, some was desaturation, some was CO2 rises. So it's very hard to compare them directly. And the predictive measures were also varied from forced vital capacity, which is the typical spirometry we do, to inspiratory vital capacities are done a little bit differently. So it's not a clear cut to compare them, but one of the trends that does emerge is that the lower your vital capacity is probably the most predictive of sleep disordered breathing out there. And the lower it is, the higher the chance is that we're going to start to see that. And we do start to seeing below 40%, almost all individuals who will have some degree of sleep impairment. But the other thing we start to see as well is that there's some studies that show there's absolutely no correlation, although a lot of times these are more advanced patients where all of them are below 60% FVC. And some of our more recent studies from Canada are actually showing that the sensitivity specificity is not as good as before. So part of things when we try to bring this all together is we know with sleep disordered breathing, the first thing is that you start getting some REM-related obstructions and maybe some desaturations during that. As you start to progress, you start to have some more central apnea, some worsening, and some more actual hypoventilation during REM. Eventually, this progresses to hypercapnia throughout the entire sleep cycle, and then you get your diurnal hypoventilation. There is an overall correlation that once you start to drop less than 60%, you're going to start to see these milder REM-related obstructive apneas that are not going to be associated with CO2s. As you start to get to less than 40%, you're going to start to get more hypercapnia throughout the sleep cycle, and as you're less than 30%, you'll have more diurnal hypoventilation. Again, it's not a perfect correlation, but it does seem to come together. The problem, however, with this is, as many of you do know, is that DMD is no longer DMD. And a lot of these, well, it's still DMD, but it's not the same DMD from when a lot of these papers were done. Historically, in the pre-steroid era, the kids were often underweight, they had scoliosis. Now what we're seeing is maintaining our lung functions much better. In fact, actually 2 of our last kids we transferred to the adult side at our hospital had vital capacities around 70% and had no need for nocturnal ventilation. So what we're actually seeing more and more right now is obstructive sleep apnea from the obesity relationship in this population. And with that can happen at any vital capacity. So whereas often historically we've looked at saying once your vital capacity is less than 60%, we should start to look at this. We're now seeing that if it is less than 60%, definitely look at it, but the correlation is starting to become worse and worse over time. So what we came up with when we looked at everything all together is that our recommendation for annual screening is that if you have symptoms, I think that makes sense, or once your vital capacity is less than 60%. You should consider doing it annually if you start having infants with congenital muscular dystrophies that are weak. So especially if you can't do spirometry and it's harder to follow them around. There are certain congenital muscular dystrophies that are known to develop hypoventilation early on in infancy, so we should screen those as well. And anyone who loses ambulation or doesn't gain ambulation, we should look at doing that as well. And then on top of that, children's demonstrating clinical deterioration should be considered more than annually. So if you screen somebody and all of a sudden they drop their PFTs by 10, 20%, or now are getting recurrent pneumonias, we should look at those populations a little closer. And for now, the gold standard is still a polysomnogram, and if that's not available, doing an oximetry with capnography which is actually not what we do in our center. We still use a lot of oximetries for this because of availability issues. So when should we start this? And essentially in our whole process, I think we had 2 or 3 randomized controlled trials, and one of them was looking at the early initiation of NIV in DMD. And this was published in the 1990s. And they looked at DMD patients with vital capacity of 20 to 50% with a PaO2 over 60 and a PCO2 less than 45 during the daytime. And they were randomized to getting NIV for 8 hours a day or regular clinical care. And some of you, I'm sure many of you know this study, but this study was actually halted early because 8 of the 35 in the intervention group died. So suggesting that actually NIV was detrimental in this population, which I think we all know is not the case. There's been many criticisms of this paper, including not knowing the cardiac status of some of these patients, but most of the patients who died actually died because of secretion retention. And there was not a very good plan for airway clearance at home on them. So when the control non-NIV group got sick, they came to the hospital, they had the full care. A lot of these individuals stayed at home and probably died because of that reason. So probably our single biggest RCT tells us that NIV does not work, which is clearly not the case. The only other RCT we have looked at neuromuscular patients of all kinds of a wide age range, and they were looking at PaCO2 that was over 48 at night and normal daytime PCO2. And 12 of them got 12 got the NIV and 10 got control. And looking at mortality, there was no difference, but at 24 months, there was pretty much everyone was on NIV. So while this was looked at randomizing to NIV or not, within 8 months, all the control group ended up on the same supports as the other group. So that doesn't really tell us much in terms of better outcomes or not. But what we can learn from that is that once you develop nocturnal hypercapnia, within 8 months, most of these patients will progress to diurnal hypercapnia as well. And again, this is a very busy slide, but once we start getting past our RCTs, we have some case control studies with very small numbers. But the most convincing data that this works is based on historical cohorts. For many, many groups, we know that the natural history of DMD pre-treatment was death around 18 years of age, 18 to 19 years. We can see certain groups have shown survival at least at 25, and other groups have shown survival into their 40s as well. So clearly this works, and I don't think we'll ever have proper RCTs to show this for us. So what we came up with then was consideration of initiation non-invasive ventilation is definitely diurnal and nocturnal hypoventilation. And we also think that this is coming just based on recommendations from the American Academy of Sleep Medicine, that if you have any obstructive events early on, we should probably consider this as well. And although we didn't specifically touch on this in our guideline, for our DMD patients, they're going to now most likely present with obstructive sleep apnea. Our typical treatments for obstructive sleep apnea would be CPAP. However, most experts, although there's a little bit of debate, will agree that we should look at starting them on BiPAP, non-invasive ventilation right away, because they will progress, and we may not pick up when that change has happened. So one of the other sections that we looked at as well was the home monitoring, and there's actually 30 studies looking at this altogether, and most of them on patients, on kids with invasive mechanical ventilation. Within this cohort of 1,900 kids, 358 died, of which 51 were unexpected. Of the 51 unexpected, 30 unexpected were due to a tracheostomy or ventilator issue, i.e. decannulation, ventilator unplugged, or a mucus plug somewhere along the line on that. So that was about 2.4% of all patients, and 8.4% of all deaths were equipment malfunction or some kind of equipment issue that arguably could have been preventable on that. So while it's not a large amount, it's still a significant amount of deaths that we're seeing from this reason. And what we do know is that ventilator disconnect alarms, are, especially in invasive ventilation, are probably not reliable in kids. If you have a small tracheostomy, there is a large amount of resistance still through that. So in lab studies, trachs less than 5 millimeter internal diameters are known to, you can disconnect them and they may not alarm, or they may not give you any warning. There's also, even with slightly larger trachs, you can have a trach disconnect, and if it sits on the patient's chest, there's going to be enough of a resistance there that it's not going to alarm. I mean, I think about a year and a half ago, we had a patient, one of our long-term patients at our hospital, who wasn't at the time being watched, and I remember walking in the room, and her SATs were about 75 to 80, and the trach was just sitting there happily on her chest, or the ventilator sitting there happily on her chest, and there's no alarms whatsoever. We also know in terms of whether monitors work or don't work, the vast majority of cohorts that have been published with the use of with external monitors. So it's harder to kind of make a little bit of a differentiation. If you look across Canada, certain programs like Alberta, nobody goes home with a home oximeter. Certain programs, such as in Ontario, if you get a home ventilator, you automatically get a oximeter. In Quebec, our PNAVD program does not pay for home oximeters. We make sure every patient from our site gets them, because I think they're very important, and hopefully at some point we'll be able to get PNAVD to start paying for them. But most of Canada does use them, but not everyone. And the American Thoracic Society published a pediatric invasive home ventilation guideline. Theirs was much more focused, and it was done more recently than when we had started ours, so it was really PICO-based. They had, despite having 8 questions that they thought they could answer, they really had no evidence behind one of them. They only came up with one strong recommendation, and their only strong recommendation was that for any child on invasive ventilation, an awake caregiver should be with them for 24 hours a day. Daytime, nighttime, someone needs to be watching them, partially because we know the alarms don't work very well. So what we came up with is, and this was probably one of the more controversial ones that we have, is an awake and alert trained caregiver 24 hours a day and 7 days a week will provide the first line monitoring of a child receiving ventilation in a situation where interruption of ventilation is anticipated to lead to an adverse event, including all invasively ventilated children as well as those on NIV that are medically fragile. The one comment I'll make about this recommendation is that I wish I could have it back, and I wish we could do this a little bit differently. Having learned a little bit more, this is open to so much interpretation that I'm not sure how all of you may read this a little bit differently. And I think one of the mistakes we made with this one is we didn't define what exactly means medically fragile and what exactly means an adverse event. Are we talking about someone who's going to desaturate, briefly come back up, or are we talking about someone who's going to die if this disconnects? And there's a wide range between that. But certainly if your child, if you are worried about significant hypoxic events, if you're worried about death, they should be being watched at all times for them. Not in pediatrics, but in Quebec in the adult program, there have been multiple deaths of neuromuscular patients at nighttime on non-invasive ventilations due to equipment failure over the last 5 years. The equipment fails, the alarms may or may not be heard. In adults, we don't tend to do this, and patients have died. So certainly, in kids, we are much more. We try to probably shoot too far in terms of being overly careful, but we do recommend that these kids are watched. It's not necessarily very realistic. Again, we need to look at the built-in alarms. Use them for what they can, but they can cause nuisances. We do recommend. We are actually going to as a consensus, we recommend that pretty much everyone has an external home monitor to use. The only evidence we have that definitely if your tracheostomy tube is less than 5 millimeters, but we are recommending that everyone has that, and that these should be oximeters, not home. Not cardiopulmonary monitors. So in conclusion, our pediatric home mechanical ventilation, it's growing increasingly in Canada. That was one of the reasons why we did the guidelines, is that, as we kind of had 5 to 6 different programs, or 13 programs across Canada, everyone was doing their own thing, and this was kind of to bring everyone together to try to streamline it a little bit more. Neuromuscular disease is still the most common reason for home mechanical ventilation at home. The clinical practice guidelines will provide a guide for those needing them. They can be a very good resource, and once the whole online supplement is published, I think specific details will be much more available there. But in the end, we really have low-level evidence for this populations, and I think this is something that we all need to strive to do better with, to help guide us in the future. Okay. So that was a very quick overview of 10 out of the 75 recommendations from our guideline. Right. Thank you.
First of all, thank you. It was quite interesting. Sorry, I'm just wondering, the children with cerebral palsy aren't included in your guideline, but can your recommendations be generalized to that population as well, because they share many similar impairments?
Yeah, so I have to think back whether there is a small section, I think, on the cerebral palsy in the section on chronic lung disease. But many, so the recommendations of how the programs are set up, the monitoring, I think that's looking at all patients, all kids. Yeah, not just I tried to focus on some of the disease-specific ones for here, but this is really meant, part of the reason why this became so big is we tried to do everything, which was probably not the smartest thing to do, but and why it took so many years to get finished. But it is really applicable to all populations on home ventilation.
Thank you.
Thank you.